Good afternoon. My name is Dr. Clement Nguga. Today I'll be talking to you about um, Vibrio cholerae, the microorganism or the bacterium that actually causes cholera. Cholera, I've only seen it on TV, seeing all those Sudanese people suffering from cholera. Cholera is caused by Vibrio cholerae. That is the bacterium. And in addition, there's always, or sometimes you have a bacterium that causes gastroenteritis, and the name is Vibrio parahemolyticus. So we've got to exclude this one when we are dealing with the cholera, the Vibrio cholerae. We've got to make a difference between the two. Vibrio cholerae causes an unbelievably diarrhea, a diarrhea that is non-stop, a watery diarrhea. That's number one. This watery diarrhea goes on, it's accompanied by effortless vomiting. And when you say effortless vomiting, we mean to say, normally with the vomiting, it's not always accompanied by nausea. So nausea and vomiting. Nausea and vomiting. No. This time it's effortless. There's no prerequisite. There's no nausea. It's just vomiting. We call it effortless vomiting. And this is this vomitus and the diarrhea that you see, and that's non-stop, the watery diarrhea. You look at the diarrhea changes from being watery, and you start seeing flecks of mucus, which are whitish, flecks of mucus, and they call it, rice water diarrhea. Rice water diarrhea. It has changed now from the water diarrhea, just water. But now, when you say rice water diarrhea, you mean to say it has got these flecks, white flecks of mucus. And this is the type of diarrhea that drains the patient. And the patient loses a lot of fluids. The patient loses a lot of electrolytes. So the body is now deficient of electrolytes, and the water has gone right down. I mean, the patient is dehydrated. The skin turgor is affected, and the patient literally gets dehydrated in an enormous fashion. So now, what you notice, which is unmistakable, is that the patient goes to the loo, but very seldom. In other words, there's what is known as oliguria. Oliguria is this, the patient, it is said, in an hour, he loses 1 liter of water. 1 liter of water. There will be nothing going to the kidney. So the kidney has started to be affected now, and such that it tends to have what is known as oliguria. In other words, very few trips to the loo to pass out water, because there's actually no water. The patient is losing a lot of water. So now, when there's oliguria, it means the kidney has started to be affected by this. So it's an organ now that is affected by this loss of electrolytes and loss of water. Now the fluids are lost tremendously. And if this happens, the next thing that you notice your oliguria. The next thing that you notice that the patient has uremia. Urine is supposed to be excreted. It's not supposed to go into urine. Urine is not supposed to go into blood. When it goes into blood, that is called uremia. So when there's uremia, there's definitely a problem now with the kidney. The kidney is not doing what it's supposed to do. Remember, the kidney is an excretory organ. It's supposed to excrete what? Urine. It's supposed to get rid of urine. It's not supposed to keep urine such that urine now gets transmitted to the blood, gets to the blood. No. Uremia is not what we're supposed to get. Uremia, because uremia is going to cause something else. Once there's uremia, is going to cause inflammation of the pericardium. You know the pericardium? What is the pericardium? Pericardium is that pouch that houses the heart. So it gets inflamed. And when it is inflamed, it's called pericarditis. So it causes pericarditis. And uremic pericarditis, it was caused by the urea that is in blood. The urine in blood. Blood is circulating right through the body, and it circulates until it gets to the heart, and even to the pouch of the heart, the pericardium, and it causes what is called uremic pericarditis. And once you have uremic pericarditis, you have a problem. You have a problem because uremic pericarditis normally causes water to get into the pericardial, the pouch itself. It gets into the pericardium, water getting in there. So you've got pericardial effusion. Pericardial effusion, which will ultimately cause, so that heart is now in water, is now in just water. And that is known as pericardial tamponade. Pericardial tamponade has got this one big problem. It will impede the ventricles, both ventricles, the right ventricle and the left ventricle. If it impedes the right ventricle, remember the right ventricle is supposed to push blood to the lungs for oxygenation. And this is not happening now, because now there is this obstruction by the pericardial tamponade. Pericardial tamponade sits on the right ventricle, and it obstructs it so that blood, which is supposed to be oxygenated, doesn't get oxygenated. And then the color of blood now changes. It becomes bluish coloration. And that bluish coloration is given a special name. You call it cyanosis, because there's carbon dioxide there which has not been excreted. There's carbon dioxide which has not been all the excretory products have not been excreted. Remember, it was supposed to go to the alveolus, to the lung, so that it can be breathed out, carbon dioxide can get out, and oxygen has got to come in. So the blood can't get oxygenated. Remember, when it is oxygenated, it becomes red. The blood becomes red, sparkling red, because it has been oxygenated. In other words, it got rid of carbon dioxide, and in the place of carbon dioxide, it was replaced by oxygen. That hasn't happened. because of the obstruction of the right ventricle. It's obstructed by what? It's obstructed by the pericardial tamponade. This is bad. And this happened because of what? Of uremia. You first of all developed what is known as uremic pericarditis. Uremic pericarditis, pericardial effusion, pericardial tamponade, and the tamponade obstructs. Now tell me, what happens when it obstructs the left ventricle? When it obstructs the left ventricle, you see what is known as a precipitous drop in the blood pressure. The blood pressure crashes down, the blood pressure. And when that happens, something else is going to happen. The brain is not going to take this. It's going to instruct the heart to start beating fast, because this is an emergency now. The brain is going to interpret this as having no blood, and because the outlet in the left ventricle has been obstructed, and it's obstructed by something that is known pericardial tamponade. It's obstructed. It's pressing it so that the outlet doesn't become proper. So the outlet, that blood, must remember, it was supposed to be sent to all the parts of the body, oxygenated blood. But now this oxygenated blood is not sent to all the parts of the body. And therefore, there's what is known as a precipitous drop in the blood pressure. And this precipitous drop is going to give rise to a tachycardia, which now the brain can't take this. It interprets it as a loss of blood. There's no oxygen, there's no food. If there's no oxygen, there's no food. The brain can't take that, so it instructs the heart to start beating faster. So we see a tachycardia. So these symptoms, like a tachycardia, when there's a vibrio cholerae, it is because of the fluid that has been lost. It is because of the electrolytes that have been lost. So now you start seeing a tachycardia, you start seeing a cyanosis, and this is terrible. This is not something that we expect. And this is something we need to make sure that there's intravenous replacement of the fluids with isotonic saline. And you can give isotonic saline. I mean, you look at this. In 1 hour, you lose a liter of the fluids. In 1 hour, a liter. So this patient is going to be dehydrated. So you've got to replace that with the normal saline. You need isotonic saline, and then you can even add isotonic bicarbonate as isotonic bicarbonate solution. Give that isotonic saline solution, and you give it, and give it intravenously. You want to make sure that at least something is done to make sure that there's a replacement of these electrolytes. There's a replacement. Well, because there can be a supplementation. There's, the kidney chooses to maintain metabolic alkalosis. In other words, it has got the proximal convoluted tubule. It has got the distal convoluted tubule. The distal convoluted tubule will reabsorb the sodium bicarbonate to try and maintain metabolic alkalosis. And that's what it does. But now, if that is beaten, in other words, this is the normal. A normal kidney accepts that responsibility, a responsibility of sodium bicarbonate reabsorption. It as a responsibility, it will do that. In other words, to maintain metabolic alkalosis by absorbing sodium bicarbonate. You know what makes alkalosis? Alkalosis is because of the bicarbonate that has been reabsorbed. But now, if the kidney fails to do that, then you're going to get what is known as metabolic acidosis, where now the bicarbonate is out, goes out, instead of being reabsorbed. It goes out. When there's metabolic acidosis, this is a real problem with the Vibrio cholerae, with cholera. This is when there's metabolic acidosis. Metabolic acidosis, what is the problem now with metabolic acidosis? It is because the maintenance of metabolic alkalosis, in other words, the reabsorption of sodium bicarbonate, it has failed now. It has failed. Because it has failed, the bicarbonate is being lost. And when bicarbonate is being lost, you are shifting now from metabolic alkalosis to metabolic acidosis. Acidosis, this is the problem. Because now, this is going to change the pH of the body. You know, the pH of the body has got a set value, that is 7.4. It has got to be 7.4 all the time. Now, it's going to change now. When there's a significant deviation of the pH of the body, when there's a significant, and then it moves away from 7.4, 7.3, 7.4, 7.2, 7.1. So when it gets to those levels, now something else sets in. There's what is known as cellular, breakdown. The cellular breakdown of the enzymatic, the cellular enzymatic breakdown. The cells have got enzymes which are working there. But those enzymes, that system is going to break down. The cellular enzymatic breakdown. And the cellular electrochemical processes, those electrical processes, they break down. They break down. And that is a knock now at coma. And that is a knock. Coma is a knock at death. That's how patients who have Vibrio cholerae die. They die because there's significant deviation of the pH of the body, which is 7.4. It goes down now 7.3, 7.2, 7.1. And when it goes over 7.15, goes down, then there's a problem. That's a knock at a coma. And that's a knock. And a coma is a knock at death. And there are two things that can happen to a coma. It's either it is reversed, in other words, it gets back to life, or it goes forward. And if it goes forward, it gets to death. And that's it. This is basically what we would like. We would like to make sure that this is avoided at all costs. And how do you manage to diagnose that the patient has got cholera? You know that diarrhea, take that feces and that vomitus, take that vomitus to the lab and let them examine that. And then they normally find there's something called immunofluorescence. Immunofluorescence also gives you an immediate diagnosis. And sometimes there's a microscopy, dark field microscopy. Dark field microscopy, you're able to see all those star-like, bacillus. The bacilli moving around, they're like stars, like stars, they move around. And when you're using that, but that is done in the lab, and the lab people aces in that. So that's why you have to take your samples, the vomitus sample, the fecal sample, take it to the lab and let them do their investigations. And you know, even the immunofluorescence is an examination, but what they trust most is agglutination. They do a test known as agglutination test, and that's so the importance of when the patient has diarrhea, take something there, and when the patient has got vomitus, take something there, send it to the lab, let the diagnosis be made so that you can treat relevantly. You treat relevantly, and the only way of treating relevantly is to know a proper diagnosis. In other words, they are able to do the agglutination test. They are able to say straight away that they are able to say straight away that there's Vibrio cholerae. They are looking for that actually, Vibrio cholerae, because this is cholera as a condition where you have, a diarrhea that is unstoppable, a diarrhea, it goes on, and it's a diarrhea. It starts with a diarrhea that is watery, and it goes to flax, mucus flax, which are whitish, and that is the rice water diarrhea. And that's all indicating to you that you are dealing with cholera when you have that. And now the treatment is very important. You've got to rehydrate this patient with isotonic solution, saline solution. You've got to, you can add even this an isotonic solution of bicarb, but that is bicarbonate. Make sure that you add that. And you are doing this in addition to your kidney, a kidney that has chosen to maintain metabolic alkalosis. And by doing what? By reabsorption of the sodium bicarbonate. That's very important. Reabsorption of sodium bicarbonate. But now, when that reaction breaks down, that one of sodium bicarbonate, in other words, this maintenance of metabolic alkalosis, when it breaks down, it's a problem. Now you're going to get metabolic acidosis. And metabolic acidosis, that's not what we want to see, because metabolic acidosis is going to change the pH of the body from 7.4 and change it down. And when there's a significant change in the pH, when there's a significant change in the pH, oh no, we're talking 7.1, then this is a big problem. This is a big problem, because now there's going to be a breakdown of these enzymatic processes, cellular enzymatic processes, a breakdown of the cellular electrochemical processes. And if that happens, you are knocking at what? At coma. And if you knock at coma, you're already knocking at death, because it's either you come back or this is if something is done. And something is, when we mean something, rehydration. Potassium as well. When there's maintenance of sodium bicarbonate, reabsorption, it generates a hypokalemia, which is, it generates a hypokalemia. And those are the ways in which you see that the kidney is still functioning. Because when the kidney is still functioning, you see the maintenance of sodium, of the maintenance of reabsorption of sodium bicarbonate. But when that breaks down, it becomes a problem. I think this is what we need to understand, and with cholera, that we are going to jump and make sure that we rehydrate the patient, and also replacement of potassium. replacement of, we're going to check the potassium levels. We don't want any potassium, well, that's chatting. So we are going to replace with the sodium bicarbonate, for instance, we can add a vial of potassium, just to make sure that the potassium is at the correct levels and at acceptable levels. Thank you very much. I'm so glad that I've spoken to you about this.